A 31-year-old patient presents with a chronic cough, low-grade fevers, and weight loss. I am showing you two axial contrast-enhanced chest CT scans. Describe the findings.
The axial contrast-enhanced chest CT scans demonstrate multiple enlarged mediastinal and hilar lymph nodes. These nodes show a characteristic appearance of central low density or hypodensity, with surrounding thick peripheral rim enhancement, particularly in the subcarinal and paratracheal stations. There is also patchy consolidation in the adjacent lower lobe.
Based on these imaging findings, what is your primary diagnosis and what does the low density with peripheral enhancement represent pathologically?
The primary diagnosis is mediastinal tuberculous lymphadenitis. Pathologically, the central low density represents caseating necrosis within the lymph node, and the peripheral rim enhancement represents a highly vascular, inflammatory capsular reaction.
If I tell you the patient has a recent diagnosis of HIV and a CD4 count of 95 cells per microliter, how does this clinical history explain the imaging pattern?
In HIV-positive patients, the radiological presentation of tuberculosis depends on the CD4 count. A CD4 count below 200 cells per microliter leads to a primary tuberculosis pattern, featuring bulky necrotic mediastinal lymphadenopathy and lower zone consolidation, whereas cavitation is rare due to impaired cell-mediated immunity.
How does the presentation of tuberculosis differ in HIV-positive patients with CD4 counts above 200 cells per microliter?
In patients with CD4 counts above 200, a classic post-primary or reactivation pattern is typically seen, characterized by upper lobe cavitating disease and a lack of significant lymphadenopathy.
Is lymph node enlargement more common in primary or post-primary tuberculosis in immunocompetent hosts?
Lymph node enlargement is much more common in primary tuberculosis, occurring in up to 90% of pediatric cases and up to 30% of adult cases. It is rare in post-primary tuberculosis.
State the differential diagnosis for mediastinal lymph nodes showing central low density and peripheral enhancement.
The differential includes atypical mycobacterial infections, such as Mycobacterium avium intracellular, fungal infections like histoplasmosis, and metastatic malignancies, classically seminoma, squamous cell carcinoma, or papillary thyroid cancer.
What histopathological features define a tuberculous lymph node?
Histopathologically, it is defined by caseating granulomas containing central amorphous necrotic debris, surrounded by epithelioid histiocytes, Langhans multinucleated giant cells, and a rim of lymphocytes.
Explain the immune reconstitution inflammatory syndrome, or IRIS, in the context of tuberculosis treatment.
IRIS is a paradoxical inflammatory response that occurs when antiretroviral therapy is initiated in a patient with tuberculosis. As the immune system recovers, it mounts a severe reaction against residual tuberculosis antigens, causing worsening of consolidations or mass effect from expanding necrotic lymph nodes.
State the critical safety warnings and infection control precautions when a patient presents with these findings.
The critical safety warning is the high risk of nosocomial transmission of pulmonary tuberculosis. The patient must be immediately placed in airborne negative pressure isolation, and health workers must wear N95 respirators.
What are the immediate clinical management recommendations?
I would recommend immediate airborne isolation, obtaining 3 sputum samples for acid-fast bacilli smear and gene expert PCR, initiating standard quadruple antituberculosis therapy with rifampicin, isoniazid, pyrazinamide, and ethambutol, and consulting infectious diseases.